So what can you do with IL-2? This is one of my patients, and IL-2 is given for two indications. It's given for kidney cancer, metastatic kidney cancer, and melanoma at this point in time. And in some places where they have clinical trials, it's given in conjunction with other immunotherapies. So here's this thing. We have a CT scan of a patient. This is one of my patients, and on this one slice of CT scan, you're going to see that he has 10 metastatic spots. In a CT, for those who are not aficionados of this, if the patient's lying on his back, his nose is this way. It's as if you're standing at the head of the table like this, looking at the patient on the bed. So this would be his left. So this is his right. This is his left. His nose is going this way. So 10 metastatic lesions on this. And he had 118 spots because he was on the trial, so we counted. And at the end of the time that we were done, eight weeks after immunotherapy, the only thing left was this thing here. Everything else had gone. And in fact, we gave him 2 full courses of IL-2. And we watched this for about 5-6 months because we were nervous. And when we went in and sent a surgeon, and it was peripheral, we sent a surgeon after it, took it out. It wasn't cancer, it was just necrotic inflammatory cells. This man is now 6.5 years post-IL-2. He's a football coach. He's just doing everything. So it's an absolute unsustained, unmaintained sort of, unmaintained complete response. In English, it means your cancer is gone completely. You don't have to take any other drugs. That's what it means. So this is what you can do with metastatic cancer. And just for the reference point, in kidney cancer, untreated, or even treated these days, or your 5-year survival rate is 10% or less. So this is the kind of stuff we can do. Here's one of my patients with melanoma. In fact, this is the physician. This is the inside of his leg. He had a melanoma lesion on the outside, and this is the inside of his thigh. And these things started coming up. In fact, when he first had the lesion, they did a biopsy of his lymph node here. It was negative, but these things came up. It's actually worse than you can see because it came up his leg, involved his anterior abdominal wall, genitalia, and then it was awful. It was not resectable. So, and I would get phone calls from him because he would, every week, new ones would come up. He says, Dr. Wong, new ones are coming up. And he was one of the first patients I treated. When I got to Roswell Park, I hadn't even set up my program yet. I was doing this kind of thing, getting nurses up and running. Every week I get a phone call. So we gave him IL-2, and this is what happens after at least 2 cycles. All these spots went away. Now you have these little dark spots left. So we said, maybe that's melanoma. So we biopsied this one, we biopsied this one here, and it turns out to be just inflammatory cells with melanin. In other words, the dark stuff inside the melanoma, that's the stuff that gets spewed out when you're dead. Well, the inflammatory cells come to eat it up, and you leave a little tattoo there. And you'll notice he has vitiligo. So where there used to be a melanoma, it killed the melanoma off and sort of had this little area where it took out all the melanin cells. This guy is now 8 years out, completely free of disease. He calls me from time to time and says, what are you doing today? Talking to nurses again? I've seen 50 patients, you know. So it's this kind of thing that we're talking about. So this is why we're even having this conversation. This is the last CT scan we're showing you. Melanoma patient, 1 cycle of IL-2. Here's a CAT scan. This is 2 slices. This is before, after, before, after. Here are the spots that we talked about, right? And after IL-2, even 1 cycle, there's tremendous response. And this is a woman who had a complete response in her lungs. The nodules are gone. She's almost, she's 6 years out now. So this is the kind of stuff we can do. So the reason why we're having this conversation today is because to be able to cure patients, to be able to literally snatch them from the jaws of death is something you rarely do. It's a bit like defibrillating someone and getting them back, right? Except you have to work a little harder. Right? So in oncology, you rarely get this. So what is immunotherapy? It's a difference. Now, there's lots of things going on. So today, we're going to talk about IL-2 specifically. But the comments about immunotherapy apply for all the things you're going to hear about. IL-2, ipilimumab, there's a new one called programmed death receptor 1. There's a slew of new things coming out. So you are at the very beginning of this stuff. You're going to hear more and more and more of this stuff. And it's the new way of treating cancer. Why? Because people have sort of figured out now that in order to cure patients, you know, this is one of the ways that have consistently done it over and over and over again. So what's you're going to do? So immunotherapy is using your own immune system to treat you. So what is the immune system? Well, in your body, it's embodied in organs like the thymus gland, which is, in fact, when you're a baby and you're born, the thymus is a huge thing in the chest. And as you get old like me, it becomes a teeny weeny sliver of a tissue. But this is where you get your T cells from, thymus, right? Lymph nodes, your spleen, right? Your Peyer's patches, you have immunity inside the GI tract, your bone marrow, right? And your tonsils. And so you have a system in your body effectively doing that. And if you think about it, it's very effective. For instance, we're surrounded by germs, and yet we just don't crump to the ground every time we get a little bit of infection, right? We catch the flu. most of the time we're doing pretty good with that. So the reality is that this is a system which nature's given you already to fight off hostile things in the environment, and we're exploiting it to fight the cancer. So what is immunotherapy? We figured out what is important, the molecules that drive it. We have figured it out. We know what it looks like. We make it in a factory. We actually put it into a vial. This is the original Chiron. So Chiron was one of the first companies that made IL-2. It's actually Cetus. Cetus became Chiron, became Novartis, and now became Prometheus. So 4 or 5 companies have had it. This is one of the first IL-2 vials that people have had. So, and then you figure it out, and then you give it in a bag. So IL-2 is not a foreign material. It's not adriamycin. It's not ifosfamide. It's not cyclo. It's not, it's not cisplatinum. It's a natural, it's like insulin. So everyone in this room has IL-2 in your body already. Hopefully not too much, because that means you have an infection. But you have it already. So it's a natural issue. So it also tells you that when you give the drug, you shouldn't get an allergic reaction to it unless something's wrong with the bag, right? It's a natural product. I'm giving you something you already have. So it's not like the body says, what is this stuff? It's like, hey, it's like insulin. Okay? You've got it, it's something, so it's going to react in your body. What is this thing? What is it? It's a goblet, right? Miriam is like going like this. Miriam. It's a wine glass. Anything else?
2 faces.
You got it. It's also 2 faces, right? It's a silhouette of a woman's face. Why am I showing you this? Because the reality is white defines the black and black defines the white. So your tumor, your patient's tumor, is inside your body. It is surrounded by the body. It is interacting with the body. So we pay a tremendous amount of attention to the tumor. It says, oh, we look, palpate the tumor, CAT scan the tumor, this is a tumor, and what do. But the reality is your tumor exists within the context. So if we change the shape of the white, you change the shape of the black, right? Naturally. So immunity is exactly that way. When you are giving IL-2, IL-2 has exactly this much effect on the cancer. Well, almost all the cancers, a few do, but 0. You are not affecting the cancer whatsoever. What you're doing is changing the patient so that the patient becomes hostile to the cancer, right? So when you give IL-2, unlike chemotherapy, that tumor is not going to shrink right away, right? Number one. Number two, it means that the patient has to be able to do the job for you, right? So that's why you don't see IL-2 patients being wheeled in here that are really, really sick. We don't bring them up here. That's why? Because we know those patients cannot respond. They can't, right? They are the best of the best. We have selected them in clinics. So when you show up here, they've had their stress test, their MRI. I mean, these are the guys that can, they can give you 50 push-ups on the ground, right? So why? Because they have to have the body robust enough to give you the response you need. If they're really sick, heavily pretreated, had 10 different lines of chemo, can barely sit up, that's not the patient. Well, maybe they looked at that after we're done, but that's not the patient coming in for IL-2 because their body can't do the job for you, right? You're wasting their time. You're wasting your time, right? So that's bad. So that's important. So how does your immune system work? This is the Marine Marching Band. I like this picture because it is a symphony of people. So one person playing an instrument is not going to sound really good. It is the amalgamation of everyone coming together and working in the immune system. So this is a picture. These are B cells, T helper cells, cytotoxic T cells. I mean, these are words, but what I'm trying to give you from this cartoon is a sense that your immune system is not one thing, right? The IL-2 triggers a response, right? And it triggers a response in such a way that you want this to happen. So if this is a cancer cell right here, you want antibodies that come from B cells, in fact. You want NK cells, which can recognize abnormal things and come and eat it. You want cytotoxic T cells that come and recognize it. You want T helper cells. So it is a system coming together, right? So when someone says, well, how does it work? It works in a very complicated way, and oftentimes when you really ask scientists how it works, so I went to a science meeting this weekend, it was like, my God, I was trying to sip from a fire hose. There's so much information, but the reality is, it is very, very hard to say one thing's working, and we now know it's not one, it's an amalgamation of several things, right? So the first thing I want to talk about are dendritic cells. So we're going to talk about how the immune system works. So you're going to get in the next 4 slides an entire semester course in immunology. So. And I'm going to charge you for that. No, just kidding. So the reality is that dendritic cells look like this. They have these sort of long things coming out. They're in your body, right? And what are they? They're in your tissue. They are the front line of your immune system. They have these long tentacles. If I was a dendritic cells, my tentacle will extend from here all the way down past the other side of the ward. They have these large tentacles, and their job is to sample the environment. They're always constantly eating and putting it in material, and they're sampling. They are the rangers, the scouts of your immune system. They're out there. They're in all your tissues, right? Because when something bad's going on, it actually has to go and then bring back and tell the immune system something's wrong. So what is this? So this is a picture of dendritic cells inside a lymph node. This is an animal model system. The dendritic cells are green, okay? And what they're doing is that we're looking at them in the immune system. So it's a movie. I'm going to play the movie. So you'll see what we're talking about here. Here you go. Here we go. And look at that. They're moving around. See how they're just moving around? We're going to play it again so you'll see it. Oh, I got to go back one now. Hang on. Here we go. Look at that. See how active they are? Just completely so I'm going to move over here so you can see it, right? So you're actually going around and actually, there you go, sampling the environment, right? So that's dendritic cells. They're in your body. They're sampling all the time. So if something's wrong, it says to your body, hey, something's wrong, okay? I'm going to be standing here for a few minutes because there's some movies coming up. So this is what dendritic cells look like, right? This is the cartoon, and their job is to present things to the T cells. So if you have viruses, parasites, fungus, bacteria, dendritic cells sample it. And then they bring it to the immune system to say, is this wrong? So it's a bit like me saying, hey, listen, I found this over there. What do you think? Is this okay? Is it a bomb? No, that's it. I think it's just Wong said, wait, it must be, right? It takes things it sees on the outside environment and brings it to the immune system and say, hey, look what I found. Is it okay? Because your body has to say, oh, it's okay, don't worry about it. Or, hey, I think you have an infection, right? I think there's something wrong. Let's just, right? So a decision is made here. But the APC antigen presenting cell bring it in. Why do I even fuss with this? Because it's the first part of the immune system. It's the first trigger. And there's actually therapy for that, right? So right now, Provenge, which is used in prostate cancer, you know what that is? It's the patients, they take this out of patients, put in the antigen for prostate cancer, and then shoot it back in your body. And it works. So already people have exploited this to use this because you bring it into the body and it shows the body, hey, look what I found. What do you think? Looks okay, right? Not dangerous, I think. Should we call security? No. That Wong guy, suspicious, I know. You wanted to, but my point is that it does that. It brings pieces, right? So that's the first part, and I'm going to show you what happens. So here is a lymph node. So it brings it right to a lymph node. So in this picture, you're going to see that the T cells are these guys here, okay? The T cells are red, and the dendritic cells are green, okay? So it's a movie. I'll try to loop it a few times if I can. There you go. Here we go. Look at that. So they are running back and forth and interacting. I'm going to do it again so you can see this, right? So what are they doing? They are running back. So each one is bringing it back. It shows, hey, what do you think? You don't think. Hey, wait. What do you think, Evelyn? Okay, what do you think? Wait.
I think it's a little bomb.
Yeah, just there you go, right? Well, wait a minute. She might be wrong. So this dendritic cell here, me running around says, wait a minute. What do you think? This okay? Because she thought it was a bomb over there. What do you think? Right? This is good. So what happens that the immune system is it's going around, right? So this is how it works. So you get it now, right? So you get dendritic cells and T cells, and these T cells are inside lymphocytes, and they're showing to each other. So when you're sitting here quietly, hopefully not asleep, listening to me talk, your immune system is actively doing this right now, every day. So you can see already it's a powerful system, right? So I promised you a semester course. So here we go. All right, so what happens when the dendritic cell? So she says call security. So what is security? So if you call, what is the code what here? I don't even, code 77? Good thing I knew. What's code white? Code gray. Can someone teach me what it is? So what happens? So what happens when you call security? What do? Did they sit around and drink coffee? Don't even tell us I said this. Drink coffee. What do they do when you call them? They what? They come. This is what happens. So your immune system. And this is, look. It's not fast, but this is what happens. Your immune cells become activated. They start moving around. See that? It comes out of the immune system. And they say, okay, we're going to go find these bad guys, right? Because you already said it was a bomb. So they're running. They're not running. This is their speed. But this is an actual immune cell.
That's how their speed is.
Right. And they're looking for things that are happening. You see what I mean? So this is how immune system. So, all right, you say, okay, now, it's moving around. What happens when you find the bad guys? Well, you're going to see in this movie a lymphocyte, which is small, killing a big cancer cell, right? Cancer cells are usually bigger. So here's what it looks like. Look at this. This is an immune cell. here's a cancer cell, it's killing it, and I'm going to loop it around to how does it do it? And now it's eating it up as well. It's actually injecting poisons into the thing. So when it recognizes it, it just injects poisons that will kill it. I'm going to loop it around one more time so you can see how it does that. See that? So look, see these things? This is the injection, and then it just blows it right up. So your immune system works exactly that way. Once it recognizes it, and you know it as a bad guy, it comes pouring out and kills what you're offending. So that's why when people say, well, you give IL-2, it's going to take care of my tumors in the liver, take care of my tumors in the lung, the answer is yes. It's going to go all over your body, and this is why it's so powerful, right? It'll go to wherever you find that tumor and recognizes it as being bad and kill it. That's why it's really impressive, okay? That's why as well, when you do all this killing, the tumor cells themselves, the tumor sites themselves may be inflamed. So people ask me, Dr. Wong, while they're getting IL-2, this feels bigger. I said, of course. First, you volume overloaded, but you also can get an inflammatory response because of all this kind of thing happening, right? So this is how IL-2 works. Here's IL-2 in the middle. It can activate all parts of the immune system. You have this in your thing. The major takeaway here is that it's not one thing. IL-2 is basically a signal that tells the immune system something is very wrong. And really what happens clinically is that if anyone who's worked in the ICU, IL-2 mimics septic shock, exactly. It does. So if you have a perforated abdomen, if you have like a severe sort of infection, it will mimic exactly that situation because IL-2 pours out of the immune system to try to fight the things, right? So this is what it means. How do you give it? You give 1 week 5 days in hospital. So I typically do Monday to Friday, home Saturday. You get the rest of the week off and come back. So we have a patient downstairs whose name I won't mention because it's being filmed. But on 8, who came in 2 weeks ago, got this, went home, back again. He's on day 3 today. So week in, week out, week in. What happens? We write out for 14 doses, but the reality is that most people don't get 14 doses, right? You write them for 14 as if why? Because traditionally that's what people have done, and that's the original thing. In fact, high-dose IL-2 can be very, very deadly because this is the number that people who died. So back in 1987, there's a 3%, in fact, even before that it was even higher. 3% of patients died, or about 1 in 20 patients getting IL-2 would die, right? And you have significant side effects, including myocardial infarction, including all kinds of things. So this is 1987, but look at this, 1990, 1991. And in fact, Cumula did a survey of 680 patients after 1991, and there were 0 deaths. Almost 0, it's not 0, right? Why? Because, first of all, things like this, and we've done better in figuring out how to treat the patients, right? So IL-2 is predictable. So I'm going to use a tsunami example, right? So if you have an earthquake here, you can predict where the wave's going to be at every hour. In fact, the last time there was a bad earthquake, some people in Santa Monica died because they were told what time the tsunami's coming, so they decided to go to the beach, right? And they got themselves in trouble and drowned. So it's like, okay, not so good. IL-2 is predictable. When I give IL-2, right, sometimes I'll tell the house staff, listen, I'm a bit worried. I gave the IL-2 at 3. Listen, by about 6 o'clock, they'll have the chills. By 7 o'clock, they'll have the rigors. By 8 p.m., they'll have the fever. And by 9 o'clock, they'll have the hypotension. You can almost time it. So in many ways, the mantra is know what you're doing and get in front of the curve. So IL-2 is not a new drug. It's been around, you've seen, since 1980. So you shouldn't sit there and say, oh, gee, I was surprised about that. Okay, you can always get surprised. But the reality is it is predictable. It is knowable. So when you give the IL-2, you should not be surprised. Sometimes when I'm really worried, I give the IL-2 and call the house staff, goes, when do you have an early dinner, right? And put on your running shoes because we're going to have some issues in about 4 hours, right? So who gets high-dose IL-2? Healthy patients get high-dose IL-2. So when people get worried, says, oh my God, his heart rate's 140, and it'll tachycardic. I said, guess what? I already put them on the stress test. Before they come in here, they have to have, we look for them. We select them carefully. Before they even come in here, they've had a cardiac stress test, MR of the brain, pulmonary function test, right? So I know their lungs are good and hearts are good, and if they're 140, I'll pull out their stress test. It goes, yep. We stressed them to 145 when they were outside. So these are not the people that we just say, hey, what are you doing today? Would you like to go? We dress them up. You're only getting the top. Because it's important. Unlike leukemic patients who don't have a choice, they have leukemia and they have to come get treated, unfortunately. and you have to give them the therapy that will get rid of the leukemia, these patients have choices. We can do this or other things, that's correct, and we can talk more about that if you want, but we've made the choice to do IL-2. It's a choice. And when they come in, we've already tested them up very, very aggressively, so there are no surprises. That's why the death rate is lower now, because in the old days, we didn't do all this testing. So people came in, the heart rate goes up, they have an MI. Oop, not so good. So it's rare to have these sort of complications, right? So patient selection is a key factor. We do all this stuff. You have this in your notes. So I just want to go through this. You know, it says stress test for patients over 40. In fact, I've actually brought this down to 40. 40 in men and 45 in women. Why? Because we've been caught out a few times. And in this society, I guess with all the cholesterol that we're eating, it's a different thing. So I stress them even when they're low. They have pulmonary function tests. And we check them for CNS metastasis, right? So the most dangerous impact, brain, heart, lungs. Really, that's the big thing, right? So what do we mean by that? So here's an example of a CT scan of a patient that I saw. This is her CT scan, and you know, she came in on a Monday, and on Monday night she was having tremendous trouble. And on Tuesday morning I'm examining her, and then she actually punched me. Right? I'm like, my God, I was leaning over, and she just like, completely clocked me. So I'm like saying, all right, thank God I play hockey, because I'm used to this being pounded in the head, but just like, wow. And why? Because she had this. This poor girl had a tremendous number of Mets. So what happened with this, you know, I had a program where I got patients from other countries, and they didn't have MRI scanners there. So I accepted a CT with contrast, right? And you look at the data, it's only about a month later, right? So in retrospect, you might want to say, well, maybe, but the reality just was called negative, and we looked again, it was negative again. But what happened was the MRI scan showed the tumor, and see this little the spot around it? That's edema. So one of the problems with IL-2 is it causes capillary leak. Your blood vessels open up, and because of that, you can leak fluid out. That's why these patients are puffy, ankles are go. I tell them, watch out for your rings, right? If you have piercings, rings, they come out because your tissue gets swollen. And of course, if your eyelids are swollen, really, who cares? It's cosmetically bad, it goes away. But if it swells in the brain, you've got a problem, right? And so this poor person had a tremendous problem with this. So let's talk about this thing. So this is the blood vessel. Okay, so I drew this. I want to point out the disclaimer. It's in my family. My brother has all the artistic talent. You know, I have zero. But this is my blood vessel. You give IL-2, here's what happens. The blood vessels dilate. That's why they're hot, they're flushed, they look red, they look like they've been in a lobster thing, right? And then on top of that, you notice that it stresses the cells out, so the walls of the vessels are leaking. So not only do blood vessels open up and leak, they leak fluid out, right? That's why their ankles get puffy, their eyelids get puffy, right? Our patient downstairs would tell you when he went to sleep, like on one side, he woke up next morning, one eye was like this because their tissue around the eye is very soft and it accumulates fluid. Why? And this is exactly why. If you figure it out, you say, wait a minute, your blood pressure should drop, and that's why they are in hospital. If it wasn't for this, we could treat them as an outpatient. Their blood pressure can plummet like a stone, like a stone. So 1 p.m. they're fine, 1:15 they're not so good, 1:30 they're in the ICU kind of thing. It can plummet. That's why they're on monitor. That's why we have frequent vitals, because of this business. But I've already told you it's predictable, right? You give the 3 o'clock dose, 6 o'clock, maybe you should start looking for it, right? So now you know, right? So the severe effects are associated with this thing called capillary leak syndrome, CLS, right? Hypotension, tachycardia is the first sign. It's not surprising, right? And the number one thing is that that's why, right, the blood pressure changes, and your lung. That's why I do a pulmonary function test before they come in, because the lungs are full of blood vessels, and they all leak, and if you leak into the lung, you have a small problem. It's called you can't breathe. You can't, well, in fact, you can breathe, but you can't exchange, right, because it's full of fluid. So here's an example. So, right, you have this in your handout. What we really have to tell you is that capillary leak syndrome doesn't last forever. It lasts only for a short period of time. So what I tell nurses, and this is exactly what I mean by how IL-2 depends on good nursing. It depends on good nursing because of the fact that if I make a decision to give a dose that maybe I shouldn't have given, what I'm going to ask you to do is give me 8 hours of good nursing, because we got to get them through. That's really it. They leak, but then it gets better and it stops. And here are all the bad things that can happen. So capillary leak and decreased vascular resistance. You get neuropsychiatric toxicity. This is where they get a little, not so right and hallucinating. Hypotension, right? Their lung fluid weight gain, they put fluid. So my record for putting fluid on someone is about 45 pounds, right? Exactly. Yeah, exactly. I try not to do that, but sometimes that's where you end up, right? Sinus tachycardia, myocardial infarction, all the bad things, oliguria, they don't pass water, all the bad things you hear about, you can trace back to this capillary leak syndrome. So if you understand capillary leak, you can manage IL2. That's really what it comes down to, right? So how do you resuscitate these patients? So let's draw a picture of a blood vessel. Here's a blood vessel, right? You have capillary leak syndrome. They vasodilate and have holes. And then what happens is that the water, this is water, that's in the blood leaks out. That's your problem, right? You have hypotension. So you can give them more water, right? But one of the ways you can also give something in the blood like albumin. Now, have you ever given albumin, 25%? What does it look like? A small bottle. Does it look like, it's not, it's a little amber, but a little frothy. Does it look sticky? It's viscous, isn't it? It's like really thick. Your body doesn't like that. When you put that in the blood, you know, the blood doesn't like thick things. What it tries to do is try to dissolve it. So if this is water, and you put something like albumin in the blood, the water would stick to the albumin, right, to try to dissolve it. So it pulls the water back into the blood vessels. So you'll see that we will resuscitate. Then oftentimes they'll say, it's, you know, let's give albumin 25%. So, right, but you got to resuscitate. You got to get fluid here first, though, right? You got to. That's the first maneuver, because you have to up their blood pressure. Now you can say, well, why don't we just give albumin all the time, Dr. Wang? That's easy, just, you know, albumin, let's go, right? But here's the problem. Here's your thing, you're familiar with it now, you got the fluid out. If you give albumin too early, here's albumin, it will actually leak out. Then what you got is you got albumin in the tissue, and you're like Michelin Man, right? You're stuck now, you've got this, and you're like, right? Their fluid is now all out into the tissue, and your albumin, and any fluid you give it pulls out more. So you have this situation where it ends up here, and it's not that you pull fluid out because you can always give more fluid, but the problem is that you now have people that are hugely edematous. And then it takes a long time to get rid of it because of the fact that now you got to get not just the water to come back, but you got the albumin to come back, and that can only be done by processing it in the tissue, which is harder. So that's why, if you ask me, I oftentimes give albumin after we've had some fluid resuscitation, and later on when I think the capillary leak is over. So when the capillary leak is just starting now, that's the wrong time. But if they've been kind of like doing anything on, it's almost been 8 hours into the next 9 hours, said, okay, now it's time. You're far enough along that this is lessened, right? So lungs is the most dangerous. Again, you have this in things, so I'm not going to read it for you, but this is why we do SATs. This is why we ask them how they're doing, right? And the SATs go down and begin to stay down, right? And so basically, they start having dyspnea, they have wheezes, they're crackling. So if, in fact, when I go in a room after chatting to patients, you'll notice that they only really listen. What I really want to do is listen to their lungs. Because what's going to make them end up in the ICU is, I can't breathe, my SATs are dropping. That's really bad, right? So if you're unsure, you do a chest x-ray. This is someone on day 1, this is day 4, so like Monday, Thursday. They walked in the door, this is 97% in room air, right? Good blood pressure, respiratory rate. On Thursday, this is not so good. 4 liters oxygen, only 87%, hypotensive, right? And look at the chest x-ray, nice and clear. Here it is, it's fluid, all over the place, a little bit of fluid. So this is a person that we had to stop IL-2 because they were getting into trouble with capillary leak syndrome, right? If you listen to them, they would have crackles, rows, and the rest of it, right? So the number one thing is flu-like affecting rigors, chills, rigors, fever, because remember when you give the IL-2, it doesn't do anything right there. It's easy. The body says, okay, it's IL-2, I know what this is. But it's when it gets triggered and your body says, I have an infection. Now they don't. They don't have an infection. So house staff sometimes will get up there and just get terrified. Oh my God, septic shock, draw cultures, da-da-da-da. So please don't do that. Give me a call, right? It could be, they could have infection. That's one of the things. But if I just gave you IL-2 4 hours ago, you can more or less, I mean, the house staff got the diagnosis right. It is septic shock, but I did it to them, right? And it's going to go away in about 3 or 4 hours. But they don't know this, and your job is sometimes help them with it, right? Because we rotate staff, and it doesn't matter where you are. If you're at Harvard, they don't do IL-2. They don't do IL-2 at Yale. So even the best places don't do it. So, and there's only about 60-odd centers. So who knows this? You guys know it, right? All right. So the important thing is you should not have fever if you're not on IL-2. That's an important point because people always want to do cultures when you see it. It is. It looks exactly like infection, right? And if you have junior nurses, they don't know what infection looks like, just ask them to go look at the IL-2 patient. That's classic, right? On the other hand, on Saturday morning, when you hadn't had IL-2 for over 24 hours, you shouldn't have a fever. Remember, these people have lines in, and remember, they can get infection. In the old days, 3% of patients actually died. And they died because we used to treat them with indwelling lines. We don't do that anymore. As you know, I take the PICC line out because of the very fact that when people went home with the lines in, they get infections, right? So for some crazy reason, you're a little bit sensitive to infection, more susceptible to infection when you're on IL-2. Makes no sense. You're stimulating the immune system. You should think they should have the world's best. But it turns out the immune system, instead of turning its attention on to bacteria, it's trying to turn its attention on things like cancer and large things like that. So it gets a little paralyzed by that. So the number one thing is if on Saturday morning on discharge, if they haven't had IL-2, they shouldn't not, because IL-2 doesn't last. Remember how 8 hours of good nursing? Remember we talked about that? You shouldn't be having fever. That's when you should say something's wrong. That's when the house staff should come up and say, you know, the whole thing, do the whole thing, and that's the right answer. So it requires a bit of discretion and knowledge, right? We're going to talk about the fact that they can have counts that go up or down, right? And one of the things that can happen is that they can have a rebound white count when they go. Why do I even mention this? Because when they come back in the second week, sometimes I get nurses will come, oh my God, his white count is like 18. I said, okay, great, fantastic, that's good. But if you have a patient come in for chemo and they're 18, you should think something is not, the house staff at least should say something's not right. You got to explain that. So, right? And it's crazy. IL-2 can increase the risk of having sepsis. And it all has to do with catheters. So I take them out. Not all of us do that, right? But I do. And that's why they're on oxacillin when they're in-house. The orders will have antibiotics. That's why we just continue to go home. It's to prevent this issue of sepsis from lines, okay? Neurologic effects, they get worse before it gets better, but now you know, hallucinations, remember Dr. Wong, tall, good looking, lots of hair, six-pack, that's not the right uptendation, disorientation. And be careful because sometimes, you know, there's a little Ambien on order and there's some Benadryl. So if you've had day 4, they're itchy, they had a slug of Benadryl, and then they had like an oxycodone, and then they have an Ambien, and then you get the IL-2, they're like absolutely gaga. You're even looking at me like, yeah, you'll be gaga as well. But remember, right, this is an issue. But the thing that's important is that they'll have hallucinations and global dysfunction, but they should not have focal things. What do you mean by that? They shouldn't have a lip job. They shouldn't have suddenly an arm that goes. They should not suddenly say, you know, my leg is weak, only my right leg, right? They shouldn't poop in their pants, right? Why? Because it's a global effect in the brain. Whereas the things I talked to you about are focals. There's a spot, something's wrong, right? So because of that, you have to understand if they have focal neurologic symptoms, soft, eyes not working, that's very different than saying Wong is tall and has a six-pack. You know what I'm trying to say? So I'm using it as an example to remind you, global dysfunction, oh, you can explain that. Focal, you can't, okay? Here's an example of a patient I gave IL-2 to, and if you're astute, you'll notice that between scanning him and coming to IL-2 within the 6 weeks, or in fact, he went on vacation, so 8 weeks between the scan and coming in, he developed this. And this man was being treated, and the nurse says, you know, suddenly, he can't eat it. What do you mean? His spoon is not hitting his mouth. It's like kind of like hitting his face. And what happened is he had weakness, so he was just kind of like food's everywhere. Like, wow, what's going on here? It turns out that it was in a motor strip, and he was having trouble with his arm. He was having a focal neurologic event. His arm wasn't working. So that's different. That's important. So the take-home message is, we're getting to the end now. IL-2 consistently cures metastatic kidney cancer and malignant melanoma. And cure means you treat someone, the cancer goes away completely and forever, right? That's incredible when you think about that. Because these are not people coming in with 1 or 2 spots. These are people coming in, like my patient, with 118 spots in their lung, right? It does not work in every patient, right? So we've got to carefully select them, and there's a workup, right? And therapy requires an experienced unit. That's you guys. That's the only way to make it work, right? So the way to do it is you know what the side effects are and get in front of them. Don't be surprised. Everyone's got an issue. So every patient's a bit different. Some people have a lot more capital leaks. Some people have a lot more diarrhea. My point is that that's a thing that's going to be a problem. So you anticipate. You say, okay, now this is the problem. If hypotension is a problem, and Wong's going to give another dose, guess what the problem is going to be in about 4 hours? Hypotension, right? It's not a secret. So put the fix in, right? If we're unsure, hold the dose. So even if I say give the dose and you're unsure, I'm giving you all permission to hold the dose. We can talk about it in the morning. You got to have a good reason. But you're at the bedside. If you think it's not the right thing, then don't do it, right? Because sometimes things happen very quickly, right? I said the example. 1 o'clock, you're fine. 1:30, you're in ICU. it can happen that quickly. So sometimes after we speak on the phone, you're just like, oh, da, it's fantastic. Walk in the room, the guy's like, you're like, okay, we've got an issue here, right? Because of the things that can happen. It can drop like a stone, right? Right? And when you get better, you can march on, right? So the idea is to know exactly what it is, right? So this is the 8 ball. So that's the last slide. And I think I'm out of time. So I'm here for a while. If you want to ask questions, I'm here. And I appreciate it. Yes?